Good evening, everyone, and welcome to our Shared Medical Appointments in General Practice, a practical session webinar. My name is Jay Buller, the Workforce Development Team at Western Victoria Primary Health Network, and I'll be your facilitator for this evening. Alongside me, we've got Erin Crumans, also from the Workforce Development Team here at the PHN. I'd like to begin by acknowledging the traditional owners and custodians of the unceded lands and waterways. We recognise their diversity, resilience, and the ongoing place that First Peoples hold in our community. We pay our respects to the elders, both past and present, and commit to working together in the spirit of mutual understanding, respect, and reconciliation. We support self-determination for First Peoples and organisations. Majority of our webinar recordings are freely available on our PHN Learn YouTube channel. There is a link in the chat for you to access these. Please see on the screen at the moment our upcoming events. You can register for these on our website, and there's also a link in the chat for you to follow to this page. We would like to highlight a few key face-to-face networking events happening across Western Victoria during March. Take advantage of the opportunity to network with peers and enjoy a complimentary meal at either a GP dinner or a practice manager and practice nurse breakfast in your region. Registrations are now open on our website. If you've come into the webinar tonight not displaying your accurate first and last name, please type your full name into the chat box. Only I'll be able to see this. This will ensure that we can issue you with a certificate of attendance and you can obtain your accreditation points. For this evening's webinar, all participants will remain on mute. If you have any questions, please type them into the Q&A box and Erin will ask them on your behalf to the presenter during the Q&A time. We'll put a link in the chat box to complete a short survey at the end of the formal presentations. And I'll also show this slide again with the QR code. Our presenters for this evening are Dr. Michael Axtens and Professor Karen Dwyer, and I'll now hand over to you, Michael. Thank you.
Thanks very much, Jade. Welcome, everybody. Some of you will have met us before, but I'm Michael Axtens. I'm a semi-retired GP who's now an academic, and my role in shared medical appointments has been facilitator, and I've been working quite closely with Karen. So I'd like Karen to introduce yourself.
Yeah, sure. Hi, everyone. I'm Karen Dwyer. I'm a nephrologist and I currently work at the Royal Melbourne Hospital, but I've been working with Michael in the delivery of shared medical appointments over the last 2 to 3 years. And I guess tonight we're here to sort of give you our learnings if you're interested in implementing them in clinical practice.
And the way we're going to do it is a little bit in parallel. It's a bit meta. We're going to do it as if it's a shared medical appointment, because shared medical appointments focus on the agenda of the patients. We want to focus on your agenda. It's a new concept to some of you, whereas others know a little bit about them. So I do have a presentation, but it'll be very short because the main focus is on questions and dealing with the specific questions that you have in different contexts. So I might share my screen just to start that. So we also would like to acknowledge the traditional owners of the land on which we work and live. We're on Wadawurrung country here. I'm particularly grateful to First Nations people for teaching me a lot about relationship with the earth and how vital it is to health. And a brief taste of that in the 80s has led to a passion for lifestyle medicine. So I'm very humbled. The other thing is that shared medical appointments are called medical yarn-ups in First Nations, in the First Nations communities, and they are a way of incorporating storytelling, sharing experience, and there's a magic in that. Disclosures. So some of my funding has been Servier, Western Alliance, GMHBA, Epworth Research Foundation, no perks. It's all been really just to deliver this new model and to evaluate it. So we've been doing that for a few years. Karen, did you want to add to that?
Similarly, I have received funding and honorarium from pharma companies, but they are completely separate to this work.
And they've, even when we have been sponsored by farmers, they've we've said, oh, but we're going to be de-prescribing. They've said that's fine by us. So I have to say that's been actually quite refreshing. So, yeah, what are shared medical appointments? This is very important, this definition. They're a series of consecutive individual medical consultations in a supportive group setting where all can listen, interact, and learn. So they're not group education sessions. They're not support groups, but they do have features of all of them. And they basically work alongside conventional medical appointments. And I can't read my own slide because it's obscured by faces, so I'll work that out while I'm talking to you. The structure is the same structure as we're going to do today. Basically, generally, you have a facilitator who might be anyone. It might be a allied health practitioner from the practice, or generally you need a champion, somebody who's got a little bit of communication skills for group settings, but somebody who works well with the primary healthcare provider. And in my case, it's mainly been with Karen, although I did do some work before this in general practice with Mark Davies, a general practitioner in Lara. So what happens is the facilitator welcomes people, gathers them, goes through confidentiality, Medicare compliance, which is important. They need to be sequential appointments, even though others can participate. You need to focus on each person, each patient in turn to satisfy it being a consultation. And explains the facilitator role, works out about confidentiality and safety, talks about obtain consent, both for participation and for the billing arrangements, and then goes into a collection of themes, which are the clinical themes. Then it's talking to each patient, saying what brings you here today. And so in my case, I'd say, what would you like to discuss with Karen today? And it's making sure you don't miss an agenda. So that's the prime thing. What else? So it's an open-ended question rather than is there anything else, which people will say no and shut down. What else? What else? What else? Until they run out of steam. And then I will whiteboard them, which is what I'm going to do with your questions soon, and work out which are the common themes, and that helps to determine the order. The order is not just determined by the common themes, because you've got to have some sort of priority for the things that take medical priority. So if there's somebody who says they've got chest pain, it might be unique to them, but it has to be dealt with up front. And obviously something's happened, because you generally wouldn't want somebody with an acute medical problem in a shared medical appointment. That's generally better for the conventional system. Yeah. Karen, and then at that point, I would say to Karen, look, Karen, I'm thinking this would be the ideal way of running today. I'm thinking that so-and-so should go first because, and then I would throw to Karen, who would then, do you want to talk about what you then do, Karen?
Yeah, so whilst Michael is doing the introduction and collecting themes, I tend to review the notes. So if it's patients I've seen before, if there are any outstanding blood tests, I tend to print those out so that we can use them. I can provide a copy, or we can use them with consent to explain an issue. So I'll be doing what you would normally do in preparation for seeing a patient, but I just need to do perhaps 8 or 10 at once. So I sometimes am half listening to what Michael is doing, or sometimes I'm in a separate room, and then I come out and I really am guided by the facilitator. So Michael will direct me that we will be talking about or talking to so-and-so first who has this particular concern. And then it really, for me, feels like just a one-on-one consultation, because I move my chair in front of the person I'm speaking to, and I have that consultation. And if there are some discussion points that are relevant to other people, Michael will flag those, and he will chunk and he will check and summarise, which is really helpful from a clinician's perspective.
Yeah, and so generally I'm sitting back at this stage, just scanning the room, looking for non-verbal cues, looking for signs that somebody's not up to speed, which sometimes we overlook. You can't pick up all the cues, but generally, if there's somebody who's either nodding or somebody who's frowning, if without interrupting Karen's flow too much, and this can be a bit tricky, I might say, Karen, look, I noticed when you were talking to so-and-so that so-and-so over here was frowning. Do you mind if I just quickly check on that? And then we'll return to the person that they're talking to. So the focus has to stay on the person who's having the consultation, but others are invited to contribute if it's relevant. And also, it's quite often as a group forms very quickly. So the main subject will often say, oh, yeah, no, I'd like to hear from so-and-so about their experience. And my job is just to make sure that it doesn't get railroaded by the other person, and we always focus back on the other person. Then directing the traffic after that. Yeah, but the interruptions, yeah, how do you find them, Karen, when I'm intervening? Because there have been some occasions where it's been tricky.
Yeah, no, well, I talk too much, so that's fine. No, you usually allow me to finish an idea or a concept, and then you'll do, am I hearing you correctly? Or I just want to summarise to make sure I've got it right, and it's said in a different way. So it's actually, it works, I think it works quite well. And I think if I am giving information that is not hitting the mark, the interrupting or jumping in earlier is actually a good thing. So I think it's worked really well.
It does require quite a lot of trust between the two people and getting to know each other. But we both find that we've got each other's back. You know, none of us are perfect. And so just the corrections that you make during the consultation, the feedback from patients is, oh, I never realised that doctors talked like this. I never realised I gave that much thought to things. There's a lot of that recognition. So it's actually quite good fun. And then there's summary and takeaway. So once everybody's had their appointment and you do a quick check about outstanding items, and signposting, sometimes we've had some big groups up to where we just haven't been able to deal with everybody's agenda. So we will signpost them for another day. So my rule of thumb is you never leave without an agenda item being either addressed or signposted and prioritised. And some things you have to direct back to one-to-one, face-to-face, particularly confidential things, intimate things. That's all very upfront at the very beginning. Don't share anything you're uncomfortable with. And the other thing is, if people share things here, you need to know how to talk about it outside so you don't identify them. So we spend some time doing that. So just a check on safety, a bit of teaching back, and then some takeaway points for each one. And that's where Karen and I bounce to each other. We check that blood tests, tests or things that need to be ordered can be done, who needs prescriptions, who needs referrals. Karen, what have I missed in that?
No, it's a big session because it goes for a couple of hours and there's a lot of information that is conveyed. So one of the things that we have introduced is at the end, we've called it a newsletter, but it's essentially a summary of these are the main points that we talked about, and that goes out to every participant afterwards. And I think that's been a really helpful addition. Creates a little bit extra work, but it's been helpful.
Yes, I'll just fly through just the basics, just some informative slides. There's only a few slides just to show you what happens in a shared medical appointment. Then we'll actually start by hearing what people want to know or have to share. So this session, we're going to do pretty much the same sort of model: explanation of purpose, overview of SMAs, a little bit about, we're doing some research this year down in Warrnambool with a roadmap to try and develop a roadmap for general practices who want to introduce shared medical appointments. So we'll be co-designing some shared medical appointments. Then I'll whiteboard your ideas and concerns. So there's this bit of a communication skills acronym here, ICE, ideas, concerns, expectations. And you often add impact, what might be the impact on your practice if you're doing these. We'll address the questions, hopefully consider them all, and any outstanding issues will be signposted because Westvic PHN is planning to do a bigger echo series on these as this model emerges, because it's still embryonic despite 20 years of people plugging away, and despite the need for transformative models that GPs enjoy, we're still pushing. And we'll do a recap and plan our next steps. That slide didn't advance. Here's just a little example of my very messy whiteboarding of a real shared medical appointment. We had 8 patients. I'll just leave you to have a look at that. You can see there's a bit of emphasis on, well, metabolic health, which has been our major, like everyone we've done has been metabolic health, hypertension, diabetes, kidney disease. The overlap is, and the upstream determinants are very similar, if not the same, Karen. Yeah, so you can have a look at the issues. We've done them in both face-to-face and hybrid model. Well, we started with a Zoom model where we were dealing with patients who are on dialysis. I'm not going to harp on our results, but often we're getting people who have really plateaued with standard care. So given that we're starting with people with really, you know, who are, we've selected the hardest patients, despite that our results have been pretty good. And that slide's pretty self-explanatory. I think you can all read. So cholesterol, triglycerides and HbA1c, HDL cholesterol. If you don't believe me about quality of life, he was a man who was on the verge of retirement. He said that his shared medical appointments and his methadone work were the 2 things that would have kept him in practice. He wished he'd known about them earlier because he really enjoyed them. That VR code goes to a link to a short video that GMHBA made about shared medical appointments on YouTube. Some research has been done on in other PHNs. So this was Coordinator, which is southeastern New South Wales, and they did a really comprehensive study on shared medical appointments. I'm not going to harp about the results, but patient satisfaction, provider satisfaction, good levels of engagement, improved health outcomes and practice efficiency. And I don't know how they measured all of that because it's very much depends on the model. This is a really nice article that just shows the advantages of shared medical appointments, and our experience has been very much sort of reinforce these findings. Friendships develop. It feels more relaxed than standard appointments, yet you're still doing really good clinical work. It's a bit weird to feel like you don't have to work as hard to get good clinical outcomes. And yeah, you can read the rest. But really, we're not here to really highlight the advantages, more to answer questions. I can only advance one way. Yeah, Karen did write an article and I pretended to contribute. But Gary Egger and John Stevens were the pioneers of shared medical appointments in Australia. They're really the founders. They've been doing a lot of work over many years to put them on the radar. They are on the health systems radar. Medicare know about them, don't officially say anything about them, but quietly are supportive. We need to push that to the next step. So that's the presentation. So really now I'll rely on questions, and I'm going to switch to a whiteboard, which means I'm going to move to another screen and just to gather questions. We do have, it's mainly online. We have one person here in person, face-to-face. So we're doing a hybrid model, shared medical appointment. So I'm going to move to the whiteboard and just wondering what the questions are.
Yeah, so we have a question asking how many patients involved in each visit.
Yeah, all right. So how many patients? Yeah, that's a quick one to answer. So we could do that, but I might just gather other questions.
Stop sharing the screen.
I'll stop sharing the screen. I shall stop sharing the screen. Hi. Sometimes I don't cope with cognitive load. Yeah, so how many patients? Other questions? Not yet. Okay, well, we'll do them one by one. Claire, did you want to add your questions?
I had lots, but one just from what you said there was what exactly do you say around confidentiality at the beginning, and do you reiterate that each time, and how do you do that?
Yeah, confidentiality. Confidentiality. Yeah.
We have another question.
Yes.
It's, I presume Karen does the billing, so how is the facilitator paid?
Yep. Yeah, that's me. It's been Karen's generosity, but I won't preempt the.
Depends if he does a good job or not.
Yeah. Sometimes I do it gratis and go home with my tail between my legs. Yeah. More questions. Yes, please.
Do patients fatigue, lose concentration throughout the long appointment? How do patients find that length of consult?
Yeah. Yeah, that's a really good question. Yeah.
How long do sessions tend to run, and how long on each patient?
Yeah.
Are there any questions Karen holds back on asking in the group session?
Can that person elaborate on that? Questions that you hold back, oh, as in sensitive issues, that sort of thing, I presume. So questions that you hold back because they're not appropriate. I'm sort of guessing that's what the question means, hold back on.
How much importance do you place on the facilitator having knowledge in the topic, content area of the SMA?
Yeah, facilitator.
Shared medical appointment, sorry, just to make sure everyone's on the same page.
I'm going to call it health literacy, scope of practice, scope and knowledge.
I'm going back to that question. It was, yes, sensitive issues, example, sexual function, etc.
Yeah. Sure. Yep.
Any issues with Medicare rebates?
Yep. I'm going to put Medicare up here. Should have written smaller.
Do you have paperwork to support this process? Consent, handout, introductions?
Yeah. Paperwork. Yeah. Consent.
How about programmed SMAs?
Yeah. So programmed SMAs are ones where you have a pre-prepared presentation on various topics that you think are going to be of interest. And we did actually start with them. So like a PowerPoint or something like that. And the other thing that we have done is had an allied health practitioner come along when people have actually asked about it. So we've had a dietitian, an optometrist, an exercise physiologist, and that's it, is it? Yeah, that's it. All right. Yeah, more?
Yeah. How do you select patients?
Yeah, select patients. How many patients and who?
Room used, size, access to drink for long appointments.
Yeah, so we'll call that the context or the setting in GP. Oh, in primary care. I'll use GP as a pseudonym for primary care.
Can you speak to patient retention to sessions?
Yeah, retention. Yeah, so I'm going to put that with fatigue. So what I'm trying to do is group some themes.
How did you find Zoom sessions compared to in person? Did people stay engaged online?
Yeah, all right. So I'm going to put that with, I'm going to call that disengagement. And then I'm going to put in online. See, I told you I'm messy.
Got one more question here.
Yeah.
Can you discuss any sessions that went wrong, situations which arose, which you didn't anticipate?
Yeah.
How did you cope with these?
Yeah, problems. Yeah, potential concerns and problems, definitely. Yep, absolutely happy to talk about them too.
There seems to be one more.
One more, yeah.
Practicalities of writing notes. Does Karen do this post SMA, and how do you remember who has said what?
Yeah, so questions hold back on notes. I'm putting this in just the role of the clinician. Yeah, and sorry, what was could you say the last bit of that again, Sharon?
Sure. Does Karen do this post-SSA?
Oh, post-session, yeah.
And how do you remember who has said what?
Yeah. Okay, and yeah, so contemporaneous and retention, memory retention, not urinary. But that's an issue too. You do have to have a toilet break. Okay.
Can I add to problems as well? How specifically have you dealt with negativity or disengagement?
Yeah, so amongst problems, Claire just asked, I don't know if you could hear it, negativity or disengagement, how do we cope with that? Yeah, we've had that too. All right. Let's go to the practicality about selection of patients. How many? So, Karen, would you like to start that one off? Because a lot of the patients Karen is selecting.
They just say they can't see the bottom of the whiteboard. Maybe
okay. I'll make the bottom of the whiteboard visible.
And sorry, what was the question? Talk about
disengagement. How do you select patients?
So in terms of the selection of patients, in our first group, these were patients that I was already seeing. They'd been referred to me, and they all had poor metabolic health with kidney impairment, diabetes, hypertension, so some common themes. And I really just offered them the opportunity to come to a group. So our first group session was actually quite small. It was only 4. Thereafter, we advertised, not really, we said that we were running a group, a program, shared medical appointments, where our focus would be on metabolic health using lifestyle measures. And I had a few referrals from primary care. But again, as I identified people that I was seeing on a one-to-one, I would just offer them the opportunity. And I think of all the people that I offered opportunity to, I would say probably 3/4 were interested in coming along, and I would have had a small number that just said, no, I'm not interested in doing a group appointment. So I really offered it to anyone who I thought would gain some benefit, as in they had poor metabolic health and behaviour change, and lifestyle measures would be helpful.
Yeah, the consent process. So once Karen selected the patients, she's generally consented them. And because we've had to run this through ethics, because we've done lots of research, we've got quite a lot of paperwork in terms of consent and explanation of the process. We also have go through that at the very beginning, and I go through, so confidentiality. So what I say is, when we're here, this is a medical appointment. You all have agreed that you'll give this a go, but I just want to flag that if you, at the end of the session, I'm going to check with you. If you've said anything that is really important that you don't want shared, then I'll check about how you want that handled. But please, during the session, keep it to what you're happy to share amongst the group. Generally, it takes a session or two for you to feel like the group is trusted. In the whole history of shared medical appointments, there have been no problems yet with confidentiality, and there's 2 decades of experience overseas. But there are a couple of things that I'd like you to do. If somebody shares something intimate or something that's personal, if you want to talk about it at home, you talk about it that there was a person who mentioned something a little bit like this, but don't say that they were a top financier of one of Geelong's highest firms, or that they were the CEO of the PHN, because that will identify them. So we need not to identify people, but if it's something that's important to you, then it's better to actually say, look, somebody else had a problem with their blood sugar, and what they were doing is this, and it had worked for them. But just keep it to that very general information that's relevant to you, that doesn't expose the other person. I will then check during the session just to do a reminder of confidentiality, and at the end, just as the groups consolidate, because we have the same groups, that becomes less of a concern. The consent process, occasionally people have arrived and they've sort of forgotten what it all is. So I've reminded them that it's a medical appointment and they will be seen in turn, and that I need, sometimes I have to flag and anticipate problems. If there's somebody who's an over talker, I might say, look, some of you may feel cut off by me. It doesn't mean that I'm actually disregarding what you've got to talk about. It means that I just have to plan to schedule it in at a time so that I can be fair to everybody and do justice to the problem. So the over talker is one of the problems. So you anticipate them, but you also cope with them. Yeah, I think, what have I missed? So how many patients? We've had as few as 5, which is totally uneconomic. We've had as many as 13, which burst my brain. I think the ideal number is 8 to 10. The sessions go, there's half an hour of sort of triage, and they go for 2 hours after that, so 2.5 hours total, but they vary, they can vary. Is that right about the timing, Karen?
Oh, so about half an hour at the start, and then we usually have 2 hours in total.
Total, yeah.
So it's a sort of half an hour of the triaging, and then it's an hour and a half. And that can become really tight if you bring in allied health. So the times we've brought in the dietitian and the EP, we flagged at the session before that they would have 20 to 30 minutes with the subject matter expert, and they loved it. They really loved it. But it means that you then have to get through your consultations very, very quickly.
Money and Medicare, I'm going to run them together because they're the icky things that we don't like. It's very important for Medicare that they are sequential consultations with a focus on each person in turn. The timing of when the consultation starts, you need to book them so everybody will arrive. Then the booking time actually has to coincide with when you see them. So it's a bit of a bureaucratic thing to actually say, oh, well, we started with this person, so they were the 2:30 appointment and this person was the 2:40 or 2:45 or whatever. But you charge only as what Medicare allows, which is dictated for specialists such as Karen. It's a different schedule to GPs. For GPs, it's generally level Bs. It's very rare to do anything beyond that. There are but there are some people who have used some of the item numbers for complex medical consultations, and there are a couple of item numbers that can be used, but that's up to each practice to decide, because sometimes they're utilised for other use of resources and allied health practitioners. So it's generally, think level B. So that's Medicare. The facilitator, how they're paid, we have only bulk billed. We have not got a business model because we've mainly done this as research. And part of the ethics of research is that you don't charge private fees for something that's new, even though it's 20 years old, it's still regarded as new. But we're looking at what to do now that we're so experienced in it, he says, with a little bit of tongue-in-cheek. Even the founders say, what you learn from doing an SMA is that, yes, you've done an SMA and the next one's going to be different. Each one is different because it's very focused on the learner, not the learner, the patient. We're all learners. Karen, what would you add to that?
Yeah, so as Michael said, we've all of ours have been on a bulk bill basis. We did have some research support for a group we ran out of Epworth, and we did that because we were just really learning about the model. And as Michael said, we did some research, so we were able to measure biomarkers, for example, and show them tonight. We have been thinking how we progress that in terms of a business model, and I think there are a number of options, and thinking about what other people have done. Some have had an upfront fee to enter into a program, and then their subsequent appointments are bulk billed. Others have a payment per appointment, as you would for a one-on-one appointment. It's certainly, the person paying for an appointment, they certainly get value for money, being a 2-hour appointment. Bringing in a additional subject matter expert obviously increases it certainly increased my costs because I was using a private dietitian and EP, for example, and not being in general practice, I'm not sure of all the different item numbers that potentially allied health practitioners could also charge. So Kate Clute is online, and Kate's far more experienced in Medicare and MBS items, and maybe, I don't know if Kate's got anything to add about Medicare, and I'm putting her on the spot there, but maybe.
Yeah, we talked.
Thanks so much for that, Karen. That's really helpful. I think it is one of the biggest things is to make sure that whatever you're planning on doing is Medicare compliant, which is really difficult when there are sort of some fairly nebulous directions about these sorts of things. But it's sort of that thing of making sure that if you're doing sequential appointments, you are actually meeting those sorts of requirements. Allied Health have different, they actually do have some item numbers for group sessions and those sorts of things. So I guess it depends on what you're planning on doing, making sure that you're discussing that if you are getting an allied health professional in for part of the session to see how they might be able to potentially bulk bill, but also making sure that it doesn't then clash with any other items that you're planning on billing yourself. So it really does depend on how you're planning on setting something up, and it requires a little bit of thought just to make sure that you are ticking all the boxes and that you haven't got any of those things that somebody will potentially create a red flag because you've conflicted two different item numbers.
Yeah, and just to add to that, Medicare does have a specific definition for what a group is. And these do not qualify as a group appointment because they're generally people who know each other in the Medicare definition. So these, what we consent to, or what the patients consent to, is having their own consultation in the presence of others. Medicare can't stop you from inviting other people to your session. You can bring along your supporters to your consultation with your GP. In terms of there's a couple of other practicalities that I'm going to group together now, just looking at the agenda items. The actual setting, because it's a big group, we found that general practices aren't set. This is our major experience as general practices. We've run them in hospital settings and in a specialist setting. But generally we have to use the waiting room, which means we have to do it after hours. We did do one with a clinic where they had a special room that was available that was adaptable. But that's a bigger clinic. You need something like a super clinic for that. So that is an issue. The other thing is the note taking. It's really handy to have somebody else taking notes. Occasionally I, as facilitator, have taken brief notes to jog my memory. If Karen's working really hard, and I'm not working hard enough, I'll take a few notes, but I do have, general practice experience, which is a huge advantage. In terms of, we have run them with people who aren't primary providers of general care or specialists, and then it's a different ball game. The facilitator has less of a prompting role, except in their scope of practice, but they still work well. Karen?
So my way of taking notes, so because you need a COVID space room, COVID safe space, we were running them in the waiting room. So I didn't have a computer nearby. So I would just have some scrap paper with perhaps two names on each piece, sort of top and in the middle, and as I'm seeing each person, I was just jotting down a couple of important things that we discussed. And at the end, because we were developing this newsletter, we knew what our sort of top 3 to 5 sort of take-home points were. So then I would write in notes and I would say, so-and-so attended a shared medical appointment on this particular day. These are the overarching themes that were discussed, what causes high blood pressure, the importance of exercise, sleep or whatnot. And then these are the specific things that I spoke to that person about. I gave them bloods or we discussed their blood results. They asked for a script. They had a sore toe and looked like gout, for example. So I would just have a couple of points just to jog my memory, and then it's always good to have a few shortcuts into your notes. But it did take a bit of time. So at the end of the shared medical appointment, probably it's another good 30 to 40 minutes to do your notes. I tend to do quite detailed notes, so that's probably partly my issue. But I guess if you can get your first part of these are the main points that we discussed, that becomes almost a cut and paste into each of the files. And then specifically, I did A, B, and C, but it does need to be factored into your time.
The other thing about notes is just to say that artificial intelligence has just about solved that problem. It can now listen to a whole consult, take out the stuff that's not really relevant, and not only provide a summary of the consultation, but actually provide a few suggestions of things you might have missed. And so there's a group in Melbourne who've got that all going schmick. I just read an article about it yesterday, and the consultants who are trying out a similar program in the States say that suddenly all the burden of note-taking is gone. They just love it. All they have to do is quickly read the summary and correct it. But it's actually more accurate at doing that than it is if you ask it a question de novo. The other thing about, programs, SMAs. I did see the other there are two things that I forgot to mention before. We did have Professor Ross Khan do a mindfulness session, which was an awesome session. And we weren't expecting to have to deal with this, but at the 6th session of our hypertension clinic, we found that stress was a huge issue for quite a large number of participants. And I was kept signposting it, hoping it would go away, but it didn't. So we did it in the last session, and it was the feedback from the patients was, thank you so much. That was the best session. That really, like, they'd just been sitting on all this stress, saying, well, how can I look after my health if I'm stressed? Programmed SMAs, we had high hopes. We prepared a whole lot of PowerPoints on sleep, stress, exercise. You can't outrun a bad diet, nutrition 1 and 2. What else did we have? We had a whole lot of things. We found that it was really hard to program SMAs because the patients would have different agendas. And in the communication skills world, we have this thing called mismatched agenda. When you've got a mismatched agenda, there's going to be a lot of stuff that just goes overhead. So we abandoned them. Karen? Yeah.
Sorry, just had a quick question. How does the sequential consults happen during a PSMA?
Yeah, well, that's a programmed shared medical appointment. It's really hard because you've got all this material, you present it, and then everyone says, okay, I want to ask about something else, and just think, we've just talked for 20 minutes.
Yeah.
So that's why we abandoned them, because we couldn't do justice to sequential consults, but the material we used, so we would just cherry pick the slides when the patient prompted it. So if you want to ask about programmed SMAs, we're not the people to talk about it. Karen?
Yeah, so I think with the program, so we've done a number where we had a program of six appointments, but we made them very much a patient agenda. So we didn't have preset content to discuss it at the sequential ones. I think what my perception, I don't know what you felt, Michael, but particularly in the last couple, was that the participants, after the first few sessions, a lot of the same questions or themes came up, which is fine. But I think what they really enjoyed was when we then brought in subject matter experts, and it may be that you could run your program in that as the doctor, you're doing perhaps, for example, session 1 and session 2, and then you have a dietitian that is the clinician in session 3, for example, and then the EP that becomes the clinician in session 4, and perhaps the doctor comes back in session 5. I'm not sure. I wonder if that might be a better way of running a program, and it might be more economical and might be a better business model. But I kind of felt that when we brought in the subject matter experts, particularly by sort of session 4 and 5, I think they were kind of glad not to have us. I think they were glad for a different perspective and someone that was a subject matter expert in nutrition, for example, and and exercise. And we could say so much, but that's not our complete area of expertise. So it was really good. It was actually really exciting to see the enthusiasm and the spark when we brought in the subject matter experts. So I'm wondering if that might be a better way to do programmed SMAs rather than go have set content, because it does take away from the patient agenda. And it becomes a bit more of an education session as opposed to a shared medical appointment.
Yeah, just to add, and I'm just reading the comment, and one of the comments that just came up from Ginny Huang. One of the things that the people who do come in, like the allied health, as facilitator, I would sometimes say, so what I'm hearing from you is this, this, and this, and this. And they said it's very rare to have the experience of having somebody say back what they've heard, and that helped them to tweak what they were actually communicating. So, and that was mutual learning for both of us. Like, I learned a lot from the dietitian, but I think the dietitian having her words reflected back was, they've all said that. The allied health people who participate have loved it. Yeah.
We just got another question.
Yeah.
Given that GPs provide lifelong care, do you think there should be a fixed number of sessions on offer, or they just happen at a fixed interval forever? And what are your thoughts on the best interval between sessions?
Yeah, okay. Gee, that's a lot of questions. The vague answer would be horses for courses. The specific answer would, because some practices, I know in the UK, they have a slightly different model. They're called group consultations there, but they run drop-in sessions where anybody can come. But they also, in the NHS, have up to 60 people with people out in the corridors listening in. This is David Unwin, I think he's remitted 800 cases of type 2 diabetes. So he's sort of the world expert on reversing or remitting, or whatever you say, pushing it into remission. How often? We find that you need a little bit of reinforcement at the begining. So I think we were having 2 weeks between the initial sessions, Karen, and you could space.
Yeah, so initially when we had, so we've done a few different models, but when we decided to run 6 appointments, we had roughly week 1, week 2. So we gave information, reinforced it, then had I think a fortnight break. So it became week 4, and then week 6, 10 and 14 or something like that. So we started with a few together and then spread them out. And that seemed to work quite well. And then last year we decided to just run a regular, once a month we would run an SMA, and we had some people that came to just about everyone, and then some that came to a few, and then didn't come, either felt that they didn't need the session or had other things on. Then there was one particularly cold July night that nobody came. Oh no, we had 3 or something. Yeah. It's very small. And yeah, so I'm not sure whether that sort of was that just endless appointment, and I sort of felt we didn't have an end game. So this year we're thinking about going back to offering a set number as a program, and then we might run another set number, whether that's 4 or 6. We sort of haven't landed on that. But I think it's probably best to have a finite number and then start again with another finite number.
Yeah. Can we talk about some problems? Because I think you learn a lot from the problems. I'm trying to cover the issues. Patient fatigue has not been a problem. We are surprised that we feel like we buzz at the end of these sessions rather than we're tired. The patients are surprisingly attentive, and the time just flies. We have had one person with very severe chronic end-stage disease who struggles and would say, "I'm so sorry, this is so interesting, but I'm falling asleep." And, there's a few people with obstructive sleep apnea, but they're very attentive. They're mainly attentive. One of the reasons I think they're attentive is because some of the advice we're giving is above and beyond the standard advice that they've been getting in when I say above and beyond, I don't wish to be elitist. We have a slightly different concept of metabolic health to what they've heard. For example, just the role of insulin sensitivity in obesity. We've always been taught that obesity causes insulin sensitivity. We find it more helpful to think of it the other way around, and there's a lot of evidence that resistance, I should say, drives obesity. They mutually, and so reduce the need for insulin, and you'll reduce the storage of excess energy and weight and hypertension. So insulin resistance is an underlying concept. It takes a bit of re-education. And Karen and I are on a very similar page there. Karen, do you want to talk about that? Because that's one of the problems, is when it conflicts with what they understand.
Yeah, I think in terms of fatigue, like we do find it very engaging, and we are buzzing. We have had one patient who provided us with some feedback that it would be good to have a break in the middle, and that we should be standing up and having a little bit of a move around, bless her heart. But, you know, it was all about lifestyle medicine. So this person was right on the mark. So I think we can sometimes forget, because we're healthy and we've got a group of people that are struggling with chronic disease. So I think fatigue is an important one just to think about. In terms of engagement, I think one of the patients once said that it felt more like it didn't feel like the doctor-patient relationship. It felt like more of a coaching kind of atmosphere, and because we really encourage others within the group to contribute, you're not just sitting waiting for your turn. And Michael's very skilled at bringing out a theme that I've been talking about, and engage other members in the group. So I think part of the reason we haven't had too much problem with fatigue is because it's very interactive. It's not didactic at all. There is a bit of teaching on the whiteboard and whatnot, but we try to get that two-way conversation going.
Yeah, and look, one of the roles of the facilitator is to jump on what's common and make it common, and so explicitly normalise things, but then there'll be differences. We often will have a champion who is so successful, and it's easy to indirectly shame other people into feeling like they have sense of failure. So one of the jobs of the facilitator is just to normalise being at different stages and having different life contexts. So sometimes I'll find myself saying, "Thank you, so-and-so, that sounds fantastic, and I'm really glad that you've had the opportunity and the means to be able to deal with this." We're not all that, like, our contexts can differ, and so for somebody and you don't want to sort of spotlight someone, but for others they're just so busy with their lives. So you normalise busyness, deprioritising of health, focus on stress and trauma. You have to be very trauma aware, which brings me to training. There are two types of training. There's the functional training about how you run SMAs, and there's the communication skills training. And one of the problems we've had is the overly talkative patient or the unengaged patient. The unengaged patient is less of an issue because they just engage magically. You give them permission to sit and watch, and you don't concentrate on them too much, and they'll be drawn in, if not by you, by others. The overly talkative, or the very generous with their advice person, we were role-playing this with the students because we're teaching SMAs at Deakin. We even had to get them to role-play. Now, Jed, and I'm making up that name, Jed, with the hand out. Jed, that's really important, and I hear that there's a big story there. I'm just a little bit concerned that we might not be able to do justice to that today, but they are very important issues. Do you mind if I flag this and this for later? But I'm just wondering what your major issue is today, just so that I can make sure that I attend to everybody else in turn. But I will come back to it, and I hear that you've got a passion for this. So it's really crowd control, and that's one of the things that stops people doing this stuff. It's not rocket science. There's a whole lot of communication skills And I would recommend Comms Lab, which is an online, I haven't got it in the resources, but it's Hayden Richards, who's an ED physician here. He's got some beautiful communication skills videos on YouTube where he's communicating with his Labrador. He must be short on actors, but he does a lot of really good work. So the comm skills they're not rocket science, there are some basic ones, and they're part of the roadmap will be how do we deal with them. Other problems, negativity. Yeah, we had a couple of people who said, this is not for me. What sort of shonky research is this? You're not collecting enough data, you're just talking to us. That requires, you have to take everything seriously and you have to take responsibility for it. So first of all, there's apology. I'm really sorry this didn't meet your expectations, or I'm really sorry that you were led to believe that this would be more like a coaching session or a group session. I don't know how that happened. We did have one session where we had to do much more explanation of what the model was, and that was a hard session because we shortchanged the clinical time, so we actually had to add in another session. These things happen in teething problems.
Can I just say,
yeah,
a really good skill that Michael used, and it was in this group where we had a bit of a rough start, was at the start of some of the sessions he said, maybe it was the fourth session, and he said, how's it going for you? You know, how are you finding this? And it was a really nice way to start the session. So that was good. In terms of retention, and which sort of goes with negativity, I guess we had a couple of people, as Michael said, that just said that it wasn't for them. One wasn't for them. The other was someone that was doing contributing to lots of different research and was just overwhelmed, I think. In terms of retention, I've actually had pretty good retention. Clearly, some people will have clashes of appointments. So we had a number of people that couldn't come to all appointments, but we had only one or two that said, that's it, I'm pulling out. In terms of the group that we were running once a month, and which was sort of outside of the research space, I only had one or two that didn't, well, one that said to me that she didn't think she needed to keep coming. And to be honest, she was doing really well. She'd made had really done very well with her behaviour change. And so that seemed very, very reasonable. So retention actually is pretty good, I reckon. There's, unless they're just being nice to us, but they are pretty good. But they don't attend every appointment as people don't attend all appointments for various reasons. Yeah.
Can I prompt you, Karen, about the issues that you hold back on and the sensitive issues? Just because Karen's very sensitive about allowing people to share, but only share what they want to share. But how do you handle that, Karen? What questions do you hold back on?
Well, I guess really you've done a lot of the triaging. So when people have brought up that they come, you've asked, what would you like to talk about? And that really provides us with the starting point for whatever the discussion is. It can then move into various areas, and it's just continually talking about or asking for consent. I don't think we've really touched on a lot of sensitive issues in the group appointment. We've certainly talked about a number of different blood tests, for example, and I just always say, is it okay? Do you mind? Are you happy for us to talk about those now? But most of them have said, I want to know what's happening with my blood test. So they're not that sensitive, I don't think. But I don't know that we've had anything too sensitive, but there have been a couple of people that have said they would like to make a subsequent one-on-one appointment. So that's where some of the issues that are not that appropriate in a one-on-one have specifically said they would like to see, have a traditional appointment. And one of the key principles of shared medical appointments is it's an adjunct to traditional. So it doesn't replace, but it's there to help with that chronic disease management. But in anything acute or or that would be better in a one-on-one, that's still available. So I don't know, and we normalise a lot.
Yeah, normalising, I was going to say. So we've had to normalise stress, trauma, like
yes, those things.
So you say we haven't dealt with it. We've had some incredible trauma come up in the groups, but you normalise it and say we've all got our traumas. It's not fair to compare them. Some people's seem really small, but they're actually very big and traumatic. So you normalise that. You normalise bad relationships, because that really helps people to, when they start saying, oh, well, I want to do this, but she cooks me this. You just say, oh, isn't it interesting how, there's different views. And sexuality, you can mention things in passing, like when we're mentioning microvascular disease, eyes, kidneys, impotence is caused by the small vessel, problems with the small vessels. You can mention it. The worldwide experience is that people will talk quite freely about that when they realise that they're not alone. And so the only, some of the most successful ones overseas, do you want to talk about the, I know what Karen's going to say, you see, because we've got that connection.
Yeah, so I guess you're right. Certainly with the trauma, we had that and the normalisation. But the group from Boston who have done a large number of these, one of the most successful groups that they did was with postmenopausal women, and apparently it was quite an emotional session to be a part of, because as soon as one person has said it, as we all know, that once one person says something, other people are willing to also talk about it. So I think that came out particularly with when we had this group with a lot of trauma. One person opened up about a tragedy in their family, and then we had quite a few people that mentioned or had their own tragedy. So I think it is that problem shared, the normalisation.
How are we going for time?
It's 8:02.
Yeah, so what time are we finishing?
8:30.
8:30. So we've got, can we take, I'm not sure what agenda items I've missed. So if I haven't answered your questions, or if we haven't answered your questions fully, can you follow them up in chat? There's a few that we sort of limited for the purposes of time and getting through them. While we're talking about that, I'm going to quickly just talk about the facilitator, health literacy and scope and knowledge. One of the things that's really important is that you have a clear understanding between the health provider and the facilitator about what their scope of knowledge is and what areas that they are not so keen to talk about, because the worst thing to do as a facilitator, and I did it once to Karen, I think, where I asked her something, she had to say, I don't know anything about that, but she said it in a very diplomatic way. And I didn't know anything about it either, so we were just both there mumbling. But if you have a clear way of signalling to each other about at what level you go to and where to say, I'm not an expert. Like, there is a bit of humility in this about your scope of knowledge. And this is what a lot of practitioners fear, is that they're going to be found wanting. We're all wanting. Karen, do you want to talk about the areas where you've had to handball away, or, what you do with that? Yeah,
so I guess in terms of facilitator health literacy, I think I've been really spoilt to have a general practitioner as the facilitator, and that's been it has probably saved me on a number of occasions. But I think having someone with a different scope of health literacy to you is really good. So that's where I really drew on Michael's expertise in areas that weren't in my area. So I think a facilitator that was a dietitian or an EP or your nurse manager or whatnot, they bring their own set of skills that you can draw on. Obviously, as the clinician, you are still responsible for the consultation. So you need to agree or be comfortable with any advice you get from your facilitator. But I do think it helps for the facilitator to have some degree of health literacy. But probably the comm skills and the ability to manage the group is by far the most important thing. In terms of my scope of knowledge, it's just like in a one-on-one. When I don't know, you don't know, and that's that's fine. I'm quite happy to say I don't know, but I can find out, or it's time to refer on. So I don't see that it's any different to a one-on-one. You've just got to be willing to say that in front of a few people. I guess whilst we're on the facilitator, it looks like we missed a question about, it didn't answer how the facilitator is paid, and that's not going to be a reimbursable component of the consultation, and so that has been a payment that, you know, from a business model, I've paid an employee, I guess, and so that would have to be a negotiated amount that you pay your facilitator. It's another worker within your practice.
Karen's been very generous to pay me, I'll just say, but we've also been doing research, so we've been limited to bulk billing without any co-payment. To run it as one of the things with the roadmap this year is we'll be testing out what sort of other models can work in a general practice environment, because that's a really important part of co-design. It needs to work for the practice as well. The efficiency, the hypothetical would be, imagine in COVID times, if all of the questions about the immunisation were handled as a bit like today. We had a group in the room, but you had a whole lot of people who were paying a lower fee to observe. So you could have participants offline who were paying customers who would get their proper consultation by telehealth, but you could have a limited rebate item for people who are just passively listening, and you get to theme saturation.
Can I just add to that? I think I'm just thinking back to when we spoke to the group from Boston, and they talked about how shared medical appointments made the practice far more efficient. And I think that from memory, it was something like 2 to 3 times more efficient. And we did a back of the envelope kind of model, and considering you've got 10 to 12 patients, and I think after a 6, you do find that they are in a better position. I think patients aren't going to be, they're better than they were at the start of your sessions. I guess what we were able to show with the changes in biomarkers, reductions in hemoglobin A1C. So are they attending practices as frequently thereafter? It's a really hard one to sort of do the economic modelling, I think. But whilst you've got people in a group practice, you're opening up other spots with the clinician. So, you're able to, I think the ebb and the flow of your clinical practice does make it viable, but taking one part in isolation will seem non-viable. But I think you've got to consider the whole thing. From the research, they would say they're 2 to 3 times more efficient from memory. I think I can provide the paper that outlines that, and I think you will see you see better health outcomes. So it will open up appointments in your practice.
I think in terms of health, in patient engagement, it's really interesting watching somebody say, "Oh, this doesn't apply to me. I can just keep on going as I'm going," and you think, "Gosh, we've got a problem here." And then somebody will pipe up and say, "I wish that I took more advice like they're giving 10 years ago, because this is what's happened to me now," and they'll mention the complications. So, and you just go, "Oh gosh, I was getting into my rational, I was forgetting about motivational interviewing, which is resist the writing reflex. You don't want to make it all right and tell them, no, you should be listening." You're just able to watch the magic. The magic of the crowd is something that it's really hard to research, but the disengaged person, we had a practice nurse who had been trying to get somebody to attend to their lifestyle for many years, put him into this group. After 4 sessions, he was still very confused. I thought that he said he had a lot of questions. I asked him, "What questions do you have?" And he said, "I don't understand anything." So that was in our 4th of 6 sessions. But the group then helped to bring him up to speed with what they'd learned over the next 2 sessions. And then the practice nurse was tearful, saying he's been on the exercise bike, his insulin requirements have gone down. and we did very little. The crowd did it. So it's a really heartwarming. The students who have been learning about it talk about it being reacquainting you with the values that brought you to healthcare. And I think it's an antidote to burnout, and it's the only model that offers really an improvement in practitioner experience. But if your experience is based on profit, it's probably not going to cut it just on that. But the satisfaction is the job satisfaction, I think, is like I wanted to retire before Karen grabbed me for these.
I guess that's one of the things we're thinking about with the roadmap is to understand from participants, from people who participate in these, what is the value of these sessions for you? And I think that's going to be a really helpful exercise to try and understand how to benchmark the cost of these, because I think it's very difficult to put a cost on. There's the cost of our time and clearly in providing that service. But I think the cost or the value to the participants, I think we probably underestimate how much impact that sort of care has. So it'll be very interesting to get participants to give a sense of what they would be prepared to pay for something like this.
The other thing is the ability to process information, because the patient gets their 10 to 15 minute appointment, but the rest of the time they're sitting there in a more relaxed, less sort of scared state where they can listen to other people's experience and contributions, and they take in a lot. You see, like as a facilitator, I love watching. Karen's focused on one patient, but I'm watching other people nodding or talk. Sometimes they'll talk to each other. Sometimes they'll come in and, like, we've had a recipe share session, which seemed a bit weird, but those sort of sessions are so practical because doctors aren't very well trained in nutrition, and there's walking, like one person came in with their continual glucose monitor, which we haven't mentioned, but they're a very important adjunct to these for our metabolic health. And he was just sharing how he'd worked out that the morning walk and refraining and changing breakfast had an enormous impact. So that sort of sharing is just gold. It takes the onus off you.
I just was reading that there's a comment in the chat there that the feedback from some patients about feeling empowered and that they've got comrades going through chronic conditions that they'd felt difficult to share and talk about. So I think it's that, Mike said it before, it's the power of the crowd. It is quite remarkable that people with quite severe diabetes, for example, suddenly feel that they're not alone. I find that really striking, given how common diabetes is, for example.
The other thing is that we've learnt a lot that we wouldn't, I think, have learnt otherwise. Like, we were surprised how many people had gout in our diabetic group, and that got us down the rabbit hole with uric acid. And I had no idea that elevated uric acid, even in the sort of higher levels of normal, is associated with chronic pain. And by reversing metabolic health, we've had a couple of patients now, that we've had two that have actually cancelled operations because their joint or back pain wasn't as severe as it had been. They were on the waiting list. That's the beauty of waiting lists. It gives you time to... and one guy who fixed his constipation after 20 years, we were not running a constipation clinic. So there are a few surprises that you learn from people. How are we going for questions? Whose agenda items haven't been answered? Please take the time to complete our post session. Oh, that's Jade. Looks like we're getting towards the end. Are there any rather than saying, are there any burning issues? Because that's a closed question. Oh, so this is the communication skills. What other questions are there before we close? Nothing happening? Shall we assume that everybody's happy?
I don't know. Interested in Michael's thoughts on SMA training through College of Lifestyle Medicine?
Yeah, look, I did it many years ago. I'm not up to date with the online module. I think they are the founders of Lifestyle the Australasian Society for Lifestyle Medicine. I don't know how much it costs these days. We've been
$300.
$300, yeah. Yeah, I think it's the only place that you can really start to get proper training at this stage. I think it needs a little bit more emphasis on the communication skills, because that's a fairly, and we're collaborating with, we're involved. So disclosure, we're on the education committee for the Australasian Society for Lifestyle Medicine. So it's, yes, do it and watch this space, because there's more input to come. They're really making it their focus now.
We have got another question.
Yeah.
How do you deal with urgent emergency happening during SMA?
Yeah, we haven't had an urgent one, but that's the other thing. There is limited examination in SMAs. So people will show their rashes on their arms or their gouty feet and things. If you need to do a more personal consultation, then it's done in another room. Karen, do you want to talk anonymously about the person who we worried that they might have angina?
Yeah. So Michael did the triage, and we had somebody that described central crushing chest pain. It's like,
not what you wanted in SMA.
Really? And so that became the first consult of the night, and it became clear that there was an unstable angina, but I was able to, it was somebody that had previously been linked in with a cardiologist, and I was able to facilitate, very early review. I was quite comfortable that they weren't acutely infarcting, didn't need anything done there and then. Where we were, it was right next to a single room, so if I had have needed to lie them down or do a full examination, we could do it. So it's exactly, I think, just like if you've got an emergency in your room, it's disruptive, but it needs to be attended to. So yeah, I don't think there's any difference, and I guess in some ways it's a little bit better because at least you've got your facilitator there, but you would clearly need to be able to move your other patients out if there was something else really bad happening. Just on the SMA training, I think I did do the modules just out of interest. I think it was okay to sort of orientate you to what the role of the facilitator is, but I think probably the best way is to see one happening in real life, and I would highly recommend you getting Michael to come along. He's got nothing else to do with his time.
Thanks,
and
Karen.
So I think he's very good.
Look, we are really keen to develop. Like, the latest thing is that we really need to build on faculty. There are a few questions coming in, so I can see them, so I'll deal with them. Yeah, so it's watch this space this year, 2024. We're just about to start the round in Geelong endocrinology services. We haven't got dates for them yet, so referral to Karen for those SMAs, and we're doing this roadmap, which will be just they're confined to Middle Island Clinic in Warrnambool, so that will just be with their patients. We basically, our research projects from last year have finished. We're doing write-ups at the moment, so we're about to publish, hopefully, the latest one that we did with on hypertension. So it's really just Geelong endocrinology this year, isn't it, so far, and Middle Island.
So Avi's got a question. Do you think it's possible to run solo without facilitator by a GP? Gee, I reckon you'd be exhausted, Avi. I know you're very fit, but I reckon it'd be really tough. What do you think?
Yeah, I think it would be, one of the things that we've found is, as facilitator, I feel like Karen's got my back. So if I communicate badly as a facilitator, or if I miss an agenda, occasionally Karen will say, don't forget about that you've written up on the board. You feel like you're supported. So it's even, and the other thing is, as a GP, I will, if I'm wanting to give advice, because I'm very opinionated, I will generally hypothetically do it. So I'll say, so Karen, if I was in general practice and I was still, seeing patients, I'd be thinking this. What do you think about that? And I'll prompt Karen. And it's only occasionally she says, get back in your box, and that's completely stupid. Most of the time it facilitates quite a good discussion. Yeah, sorry.
Yeah, I think Abby, at the end of the 2 hours, we really do feel invigorated, and it's very different feeling from 2 hours of consulting when you're doing one-on-ones and you've got to run to time and, you know, you're sort of churning through people. I find that really draining and exhausting. But to do it in that 2 hour, I think it's because you've got time, and so you're not explaining 5-minute pieces of advice multiple times, but you're giving a whole hour. You know, you're able to, you know, educate and provide information over the hour. So you're providing out so much more, and there's not that repetition, and you're not, you know, having to stop and start new consultations and get rapport and whatnot. I think it would be really hard, and I don't know that the practitioner satisfaction would be the same. I find them really quite fun actually to do. We feel very invigorated. So I don't know.
I suppose the other thing is if you know your patients well and you've got a group of patients that know each other, that would take a lot of the load off that the facilitator normally compensates for. So that'd be the only comment that I would make, that with a familiar group, if you're comfortable and they trust, you've already got that trust, then that's a big advantage. But it would be very helpful to have a note taker, because responding to the cues of the group is a high, and trying to put match stories or contrast stories, like, oh, so this person, you're getting morning spikes of glucose, whereas this person's having an overnight whatever, to be able to contrast them and say what's happening differently there. It's nice to have another person to throw up those hypotheticals and speak for the patients, especially if they're not very articulate. It's hard as one practitioner to get the unengaged person engaged, I think, when it's all on you. But, you know, we haven't, neither of us can comment about running it solo because we haven't done it.
No. There's a question about the initial appointment. Are they longer, and then sequential getting quicker? So, and with what we've done initially is that I've seen just about every patient as a one-on-one, and I give them they have quite a long initial appointment where they all get a full examination and a full history, and I guess that's kind of how I like to see patients, even if they're not part of a group appointment. Their first appointment's usually quite long, and I need, it's my type A personality. I need to have done a full history and examination. So that's so when they've come to the group appointments, I've already got some information. We did run one group where I hadn't seen the majority of the patients, and that was the group we had that rocky start with, because we just, you know, we didn't have rapport with the patients. So that made it tricky. I would have thought if these are patients from your practice that you already know, you've got that same sort of rapport as what I try to get, and so then they're not patients that you don't know. And if you know anything about those patients already, your first appointment it's probably a little bit, it's not longer, but the interactions perhaps aren't quite as natural because the group doesn't know each other. So you'll find by the second or third appointment that the interactions are far smoother and more natural. So the first one's just perhaps a little bit, I don't want to say clunkier, but just a little bit more stilted whilst people get to know the process and whatnot. But we don't make them any longer. It's still 2 hours.
Yeah, in 2016, I think it was, I did do a series in Lara General Practice. I don't feature in the video, but I'd worked with Mark, and then Patrice, who's in the video, took over. And the patients came from different GPs, so they sort of had seen each other in passing, but they gelled because it was a community practice in a smaller, let's call it a small town world, Lara. I think suburban practice, busy suburban practices or bulk billing practices, you might have less cohesion. But we're just hypothesising. Yeah, and as Alison said, yeah, starting with a smaller group, no harm in doing that and making it a shorter time. And just build up from there. How are we going? It's hard because I can't see you. I'm used to Zoom where I can see people. There's no non-verbal cues coming in.
So how long are you spending with each patient? Oh, okay. I meant more so that do you spend an equal amount of time with each patient each session, or do you find as you go along in that SMA each patient requires less time? And it really depends on what the issues are for that particular person. But certainly once they've been coming a few times, we've had some people that have arrived and said, there's nothing I really need to discuss, but they just want to listen. So that's fine. But I think because Michael, it doesn't go in the same order each time. Generally, the people at the start have perhaps the more what do you think? How do you order people? I guess would be the
yeah. So I start with the person who's got who's probably the most communicative about their problem and it's most transferable to the others. So a lot of people will come in and say, look, I'm feeling tired and I feel like a nap after lunch. So that, and then you go, so as a facilitator, is anybody else had that as an issue? Was anybody else thinking of mentioning that today? You check that out and you get the most common thing. But then as you go through, the person who says, oh, no, I've got nothing to add, part of the job of the facilitator is to say, so if you did have a question, I know you came without a question, but if you did have one, what would it be? Or what questions you have about what you've heard today? And it's incredibly rare that somebody says, I've got nothing I need to know, I'm completely satisfied. So, and it's my responsibility to Karen to generate a consultation for Medicare. But it seriously is. It's very rare that somebody will come for no reason. They don't just come to sit in. They've got a medical agenda. It's eliciting and that's just open-ended questions.
Yeah, and probably the ones at the start have something a bit more pressing maybe, or we see that as, perhaps we've prioritised that, and often the first few consultations will be longer, and then sometimes by the end, when we can see we're running out of time, Michael will go, you've got a few minutes here, a few minutes there, a few minutes there, and you sort of churn through the others, but they've been involved in all the others. So yeah. And just quickly before we finish, it says, are you sharing your paperwork so we don't need to reinvent the wheel? That's the whole idea of this research this year, is to create a roadmap that is a step-by-step process to be able to implement into general practice. So at the moment we've got bits of paper that aren't really cohesively put together.
Collated.
But by the end of this year, this is the whole point of this particular research. We've learned a lot in the 3 years we've done them. So hopefully we can have a very clear step-by-step process with the necessary paperwork.
Yeah, I can't think of any. I think I'm getting to the end of my cognitive load. Other questions? Sharing paperwork. It's 8:28. I think we've timed nicely. Any other burning questions? Put them in chat. We won't attend to them now, but we will flag them for the further development of the module for Westvic PHN. So that's part of, because it's a Western Alliance funded research project, this roadmap will be co-designing with the PHN. And we're finished. I don't know if we're finished, Erin. Are we finished?
Yeah, I think we're finished. So up on the screen, you've just got the evaluation of today's session. So if you guys could fill that out, that would be really great. But otherwise, thank you everybody for coming, and thank you guys for sharing.
Yeah, thank you.
Thanks.